Thanks everyone. My name is Jack Chiu from General Surgery. Thanks for the invitation. David wants me to discuss the surgical repair side of the parastomal hernia. No disclosure from my part. So parastomal hernia unfortunately remains as one of the most difficult hernia for us, simply because it goes against every single hernia principle that we're trying to do when we do repair. So for basic principle, when we repair hernia literally is the hole. We want to close the hole, reinforce the defect. In this case, you have a permanent hole, which is not supposed to be there. I can't close that hole. That means I take down your conduit or my colostomy. So in this case, we have to reinforce around the existing hole, which is always going to be a weakness of the abdominal wall. So when I discuss this with the patient, I always quote fairly high recurrence rate for that reason, and told them that we'll try our best to reinforce it, but the ultimate problem is that we can't get rid of your hole because the conduit or the colostomy has to be there permanently. So that's why the discussion and the repair sometimes becomes very personalized, depending on the patient's symptom and what technique we can offer based on what surgery they had before. So most of my discussion is coming out of this paper. The Europeans are much more aggressive and sort of forward-thinking compared to the North American counterparts. So this is their first attempt of trying to put together all the available evidence in terms of prevention and treatment of the parastomal hernia. As you'll see, a lot of these studies they pull are very heterogeneous, as David already alluded to, because of the definition and the technique they use. So here are some of the recommendations that we'll go through. So first thing, the incidence. David already talked about the incidence is very high. So when you have a hole in your abdominal wall, if you follow them long enough, you probably will have some level of parastomal hernia if you image them, image everybody basically. So the incidence without any repair is fairly high as expected. In terms of the difference in the incidence, most of the paper they pull are geared toward colostomy. I guess in terms of the urologic follow-up, the papers are more limited compared to the general surgery literatures for this reason. So that's why they say the incidence for the anileostomy and the conduits are a little bit less known compared to the colostomy. So is there a role for not doing anything? They can't make any strong recommendations simply because we don't really follow these patients long-term for this particular study reason. So like I mentioned earlier, it becomes a very individualized discussion, depending on the size of the defect, how much symptom they are, and what kind of surgery we're offering, and whether the patient is happy to go under an acceptable risk that they want to proceed with the surgical repair. So there is still a role for conservative management, especially in very comorbid patient, like Dr. Black was mentioning, with the cancer surgery, a lot of adjuvant chemo or even pre-op chemo that already deconditioned them to begin with. They may not be able to tolerate a big repair. So at this point, then all we can offer is conservative management, or they don't even want to go through any surgery. So they have to be aware of the potential risks and complications that David has outlined it earlier. So in terms of repair method, so we'll start with the very simple ones, meaning we just stitch close the hole as tight as, well, not as tight as we can, basically around your conduit or our colostomy. So primary suture repair without any mesh, the recommendation is that this shouldn't be used simply because it's too high of a recurrence rate compared to other repair methods. Despite there's really no good high quality head-to-head comparison in terms of mesh versus suture alone, but at least with the systemic review of all the case series together, the suture repair has a higher recurrence rate, and this is pretty much followed by most of the general surgeon. We typically will try to do some type of reinforcement in general for parastomal hernia repair if we can. In terms of relocation, meaning resiting the stoma, again, most of the study are coming from general surgery side with the ileostomy and colostomy for a very straightforward reason. To resite your conduit is not a small job. For your uretary insertion site, you may not be able to drag it to the other side very easily. So most of the study obviously is looking at the general surgery population. So it's still, I think you have to use this very selectively because based on all the case series, there is a risk of a hernia at the previous site where you take down the stoma and the new site as well. So you create two potential weak spots that you have potentially hernia development and has to repair. So usually we try to reserve these for the stoma that really not positioning very properly or is not functional. Then we will consider either resite on the same side of the abdominal wall or to the other side if it's reachable. Just to mention again, they don't have any good high quality study to head compare any of these techniques. This is more, again, based on retrospective or prospective series. So now we'll go into some of the different mesh repair type and where their anatomical location, where we place the mesh. So previously, one of the most common one we use is called the Unlaid Repair. So what that means is you put your mesh on top of your anterior rectus sheath underneath the subcutaneous fat. As you can see here on the cross-sectional imaging, you're on top of your anterior rectus sheath, and you kind of cut a keyhole mesh to surround your stoma loop and try to reinforce that area. So the next style is the intraperitoneal unlay, or sometimes referred to underlay, meaning we repair from the underside inside the peritoneum. So how you position your mesh, there's two different options. One is the keyhole style, similar to the one you see on lay, but this time you do it from the bottom side. So again, you cut a slit on the mesh, and then you kind of encircle your loop of valve, basically trying to reinforce it. The other style is called a modified sugar baker, where you take a solid piece of mesh and then you kind of lateralize, making a small tunnel using your mesh, so that when your bowel come in, the entry site is actually here and not right at the fascial edge, trying to prevent the valsalva or the abdominal pressure to push against that fascial defect directly. So on the cross-sectional, you can see all the mesh is inside the peritoneum. So obviously for this style of the repair, you have to choose the usually the coated type of mesh, so that the mesh that's exposed to the bowel doesn't cause too much adhesion. And obviously one of the concerns, especially with the sugar baker type, is that you are putting permanent mesh against your luval bowel. So a lot of these are done with colostomy, so that is a little bit more mobile as well for the sugar baker. For the conduit, you guys don't make, depending on the length, sometimes I can't make the sugar baker configuration simply because the mesentery is too short. I can't lateralize it very well, so that doesn't make that very effective, basically. So one of the key things that we still have to do when we repair from the inside is that you have to close the defect as tight as you can, obviously, around the conduit. This can be either done with intracorporeal suture, or you can do transfascial suture with the suture passer, basically to decrease the weakness around your mesh. These were not done routinely previously when we started repairing this, so the recurrence rate was quite high because there's still a weak spot around the stoma that tend to kind of prolapse your mesh into it, make the repair less effective. So this is the sublay. The next position is the sublay that David has mentioned. In this case, this has become the more popular style of repair over the last 5 years or so, where you put the mesh in the retrorectus space to reinforce the parastomal hernia repair. And you can see in the cross-section there, you are underneath the rectus muscle, but above the posterior rectus sheath. The reason being that this is a well-vascularized bed because you have muscle directly right on top. The infection rate is a little bit less, and also the mesh doesn't tend to shift much because you're in a confined space, so you don't move as much.
You primarily sew the aperture to make it narrower as well as putting on the...
Correct. So basically, depending on how you put it in, obviously if I'm not taking down the conduit directly, then unfortunately I have to make a slit on the mesh somewhere to kind of fashion around it. The idea, you don't have to be right super tight against the stoma itself, but the idea is so that there is some reinforcement on the fascial defect so that it doesn't expand, basically. We'll talk about the prevention part, where that's where they're kind of trying to focus. The other sublay technique that we use for reserved for a larger peristoma or someone that has associated midline incisional hernia is the sort of extension of one of the component separation technique, which is a transverse abdominis release, or referred as a posterior release, with a modified Sugery. So in this case, with the posterior release, what we do is we actually create a flap or peritoneal sac, and you lateralize the bowel's exit side of the peritoneum and reinforce the peritoneum with the mesh, so that they're trying to divert where the strength of the exit is with the mesh. With the cross-sectional image here, it might be a bit hard to see. We'll give you some cadaver picture in a bit just to kind of get you understand a little bit better. So here you can see this is the open case with the cadaver specimen. So this whole flap here is actually just, this is the posterior rectus sheath here. This is the cut transverse abdominis muscle, and here is basically peritoneum and transversalis fascia. Oh, sorry. The original stoma defect was created through the green arrow, which is through the posterior rectus sheath. And what we actually do is we purposely make a lateral slit on this sac that we created, so that the exit side is now on the purple arrow. And then we sew the medial portion of the peritoneum and the posterior rectus sheath close, so that essentially we lateralize the exit of the bowel. And then you can see on top, about here, this is where the exit side for the anterior rectus sheath and the rectus muscle are. Then after we done that, then we fashion a mesh into it to reinforce all that repair and basically try to divert the force where the abdominal pressure will push against, so that all these weak spot on the posterior sheath here has the mesh coverage. So overall, the recommendation is that most retrospective studies shows mesh repair does reduce recurrence rate, sometimes up to 9 times. So this mesh repair is still remain the mainstay of our parastomal hernia repair currently. So now, when you look at different type of mesh repair that we just discussed, is there a better one versus the other? Again, the study is not the best, so they can't really make any strong argument for one to the other, especially with different type of surgery the patient had. Sometimes one technique is not really achievable because of adhesion or other issues. So overall, when you look at the recurrence rate, the unlay compared to the sublay is a little bit higher. But again, when you look at all the confidence interval, they're really big. So let's just say that the study quality sometimes is a bit questionable. The sublay by number alone has the lowest recurrence rate. The intraperitoneal, the keyhole style has a little bit higher because in these circumstances you do have to make a slit in the mesh, and people blame that slit for the weakness where the hernia can recur. The Sugery one we mentioned, but again, to do that on the conduit sometimes it can be quite difficult simply because the length is quite short. Yeah.
Is there anyone who's looked at doing a sublay at the time of conduit?
I'll talk about it in a bit. Yeah. So in terms of MIS versus open, so again, no strong recommendation can be made. If you have the expertise based on their recommendation, it offers an equivalent repair, MIS versus open. You do have a slightly lower odds of morbidity when you can offer the laparoscopic approach. Direct head-to-head comparison is not really available. So what type of mesh are we going to use? Permanent type, many different permanent type people have used polypropylene, PTFE, or polyester. The biologic was kind of in favor initially more because you prevent having a permanent mesh around your bowel, which is small risk of erosion. However, the recurrence rate tends to be a bit higher based on the follow-up with the retrospective studies or the prospective ones. It does work better in the more infected field. The newer mesh, which are the synthetic degradable, we don't really have any long-term data for that. And these are based on the limited information we have, mostly on the general surgery side as well. So talking about prevention, they discuss several techniques that they have on the literature to see if they reduce the rate of hernia occurrence. So the first one they discuss is some people has basically tried to popularize in terms of extraperitoneal versus transperitoneal. So what that means is this is technically quite difficult to do. So before you make the stoma you pull through, you have to create a peritoneal tunnel. Very similar to what we do with that sublay posterior release kind of a style. But to do that at the time of your conduit development can be quite hard. I think this is mostly done for the colostomy, simply because we have more length to pull. For the conduit with the limited length on the small bowel mesentery, this can be quite hard to do. And again, it's very limited data, all with short-term follow-up. And so that's why I don't think even on the general surgery side, this has not gained a significant popularity in terms of being performed. And they obviously can't make any strong recommendation because there's not enough data. So in terms of where the stoma comes through the rectus or lateral to the rectus, the Cochrane review has tried to answer this. They do not see any significant difference wherever you pull through the stoma. But again, the collected data are based on poor quality studies. There's an RCT attempt to answer this question as well, but they don't see any difference, and the study was underpowered. So overall, the society can't make any strong recommendation. I think the majority of us still pulling through the rectus regardless. I think very few people utilize the sort of a lateral to the rectus position because first of all, it's just difficult for functioning when your stoma is kind of to the side as well as near your pelvic region. So size of the aperture, David has mentioned. So obviously, it's very difficult to quantify what size you're supposed to make because it really depends on the size of your bowel and your mesentery that you need to pull through. In an obese patient, you probably have to make the aperture bigger just because you have to pull through much deeper length. So they say that obviously you need to make enough size to pull through, and it can potentially be an independent risk factor for hernia development. The other thing that some people are actually consider is that the classical teaching is you make a cruciate incision on the fascia to pull the bowel through. So, but the issue with the cruciate is that you actually create several lead points for the fascia to break, basically, especially later on when you're putting against pressure. So some people are basically considering that instead of making a cruciate, you should make a circular incision, especially on the posterior rectus sheath when you pull through, because that's the layer usually that break first. Again, we don't have enough RCTs or big enough of a meta-analysis to answer this question, but this is simply based on physics, and some of the colorectal surgeons prefer to do the circular cut, which we'll talk about in the prevention part as well, sort of a similar idea when we do the prevention for the parastomal hernia. So finally, we'll look at the parastomal hernia prevention. Now, we know the suture probably didn't work, the technique kind of hard to quantify. So then the only thing left is, can we put a mesh right at the time when we do the stomas? So for colostomy, the European Society actually make a very strong recommendation that it should be routinely used. If you're making a permanent end colostomy, you should use a prophylactic non-absorbable mesh when you construct the elective permanent one. This is based on multiple systemic review, RCTs, retrospective, prospective, collected data. Overall, they show very low morbidity and low cost, especially when you're using a non-absorbable synthetic mesh. And then there's a significant cost effectiveness on this when you can reduce the hernia rate for preventing later on repair as well. Unfortunately, obviously, we don't have enough data to say the same for the end ileostomy or the ileal conduit, but the similar principle can potentially be transferred to the other side as well. We just don't have enough of a big pool of data to answer that question. So thinking about some of the suitable technique that you can use when we do the ileal conduit, with the open cystectomy case, the sublay technique where we, like Dr. Donald used later that David mentioned, you can use the sublay. The 10 by 10 piece, to be honest, this is not technically very easy to do because basically we have to open up the posterior rectus sheath attachment to the midline, develop that space, and then put the mesh there, and then you have to cut out a circle in the middle, and then you have to reinforce that cutout circle with the mesh cut out in the same similar fashion. You probably have to suture along that whole rim basically to reinforce that edge so that it doesn't expand and cause hernia later. The other thing obviously is that some of my repair methods actually utilize the retrorectus space quite frequently. So if you expose that at the index surgery, it makes my job a bit harder later and limited my ability to dissect in that region. So that can potentially cause some issues as well. And finally, even for the general surgery side, despite the recommendation, a lot of these prevention things are not picked up simply because some of the surgeon feels that there's no compensation for this. Because this is the end of your surgery. Think about this. You did all your job. All you want to do is pull out that loop and form a stoma. But at this time, you probably have to spend 30 to 40 minutes to make this prophylactic prevention thing, which you probably are not compensated for. And we don't have a code for this as well. And technically, you're not fixing a hernia. There's no hernia there. So a lot of people are not very keen to do that. So it depends on who you talk to. The receptive rate for doing this is not the highest, I would just say. However, so when you look at the sublay, so you have to lay that big piece of mesh there in the retrorectus space. When you're doing MIS or robotic, it becomes quite difficult. So then basically, are you going to dissect intracorporeally that whole space open and then lay the mesh and then make a hole and sew? It's going to be very challenging. So one of the common way other people sort of use as a reinforcement method is called a SMART. We'll look at quickly the schematic diagram. So in this case, you'll pull through, we use a circular stapler basically. You pull through the envelope from inside the belly with a small hole. In the case of MIS or robotic, we'll do a purse string on the posterior rectus sheath and make a small hole to deliver the envelope in. And we pull through with the purse string to tighten it. And you fashion a piece of mesh on your circular stapler, which is depicted here. And you pull through the connector. And essentially, you fire a reinforced ring with staples and mesh on your posterior rectus sheath here. And then with the leaflet, with the rest of the mesh, you sew them with intraoperative suture on the anterior sheath. So essentially, you create this conical shape of a mesh tunnel. So in this case, it's sort of a modified sublay repair because you are anchoring your mesh to the posterior rectus sheath, but you're not exposing the whole plane at the same time. So I can still probably gain access to that plane fairly easily. And then you have 2 anchor points on the fascial edge, which can break, which is the posterior rectus sheath and the anterior rectus sheath. So this has been done for colostomy, had fairly reasonable result. I did read some paper on the conduit portion for using this, but all of them are very small study, short-term follow-up as well. So similar to the recommendation that it's hard to know whether long-term wise this will make huge difference. If it translates to the send to the colostomy, then it should. Even with the short-term follow-up, their complication rate is fairly low, and the hernia occurrence rate is already compared to the other, no mesh is already significantly lower. So to be honest, I think this is a more of a feasible technique to do for a conduit, especially now you guys approach it with multiple different techniques. So that's pretty much a short run through. Feel free for any questions.